about that. Okay. So, sorry, everyone. Sometimes I have a bit of issues getting some of these things started, but really excited to be here today. And so what I'm going to do is just give a quick little introduction for the first thing that we've got going on here. Getting my notes pulled up, apologies. Had this all set up, and then of course everything always falls apart at the last second. Where did it go? There it is. Okay, so today we're going to start off by just giving a quick update from everybody here at the health department. It shouldn't take hopefully too long. We've got about an hour slotted for this, and we're going to start things off with Allie Nelson. If I'm reading this right, and Danielle Gough. So Danielle is one of IDOH's health educators for the CDC's Project Firstline initiative. She has a degree in public health from Indiana University and has led a successful career in both human and animal health. Her and her teammates' goals for IDOH and Project Firstline is to innovatively and successfully disseminate infection prevention education for Indiana's frontline workers. Currently lives in Westfield and enjoys time with her husband and her 2 pugs. So we'll go ahead and kick it over to Danielle.
Thank you, David. I appreciate it. And I'll wait till the slides start. Oh, do the slides go up on your end? I'm not sure.
We are not seeing them, Danielle.
Okay, I wasn't sure if I was in charge of that. I apologize. Stand by. Give me 1 second. I'm sorry, everybody. All right, can everybody see my screen?
No, it's
no. You'll need to go to the bottom of the screen, hover your mouse, and then a green share screen button should be available to you.
Yeah, give me 1 second. Okay. Okay, how about now?
Yes, you'll just want to put that. Perfect. You got it.
Thank you. Sorry about the technical issues. Always happens right at the beginning. Okay, so yes, so like David said, my name is Danielle Gough. I am one of 2 health educators for Project Firstline here in Indiana. Myself and Allie Nelson are both working to start implementing Project Firstline in Indiana. Over the next several slides, I hope to kind of show you how we are implementing it throughout the state. The goal of Project Firstline is to make sure that you have the infection control knowledge that you need and deserve to keep yourself, your patients, your colleagues, and your family safe. I like this. I stole this from Project Firstline CDC's website. I just thought it was really poignant in what Project Firstline is, an overview. As I'm sure we can all agree, COVID had definitely highlighted some gaps in basic infection control knowledge. And this is where Project Firstline came to light through CDC's National Training Collaborative for Infection Prevention. This is Project Firstline is being implemented throughout the country, throughout US healthcare settings. Each state has their own health education team to implement it. So every state's doing something a little bit different, but all still staying at the core of what Project Firstline is with some core infection prevention trainings. And we will learn more about what that is in the upcoming slides. So these are some key components of Project Firstline. I thought it would be important to share. Core training, practical tools, engagement, mentorship, public health capacity, and innovation. And our team, we look forward to implementing all of these throughout the state. So currently, Project Firstline has their own specific core trainings and curriculum that is really the central of Project Firstline as a whole. The first bullet point shows what the trainings are, the category for the trainings are and will be. The trainings are being released slowly throughout the year and will continue to be released as Project Firstline grows. In the second bullet point, you can see 5 trainings that are definitely available right now. The concept of infection control, the basic science of viruses, how respiratory droplets spread COVID-19, how viruses spread from surfaces to people, how COVID-19 spreads a review. There are an additional 5 listed that are not listed on this slide right now. Those include multi-dose vials, PPE Part 1, eye protection, PPE Part 2, gloves and gowns, hand hygiene, and virus strains. All of these trainings are available to everybody. They come in 60-minute, 20-minute, and 10-minute formats, so they can truly be utilized for whatever that situation is at the time, whether you have a whole hour long for a training or a quick snapshot for a quick one-on-one for a trainer, a group huddle or something. These are, so these are the core of it. There might be more coming out, but right now there's 10 posted on the website. You can find it by going to the link below that's on this slide, or you can Google CDC Project Firstline and you can find them listed under the Facilitator Toolkit. A lot of these trainings are basic and they're great for staff, for colleagues and peers, or if you want more of a train the trainer approach, that's definitely something that we've been utilizing for some infection preventionists so they can spread and disseminate this information. So Indiana, what are we doing to help with Project Firstline? This is kind of our initial plan. So when I started about a year ago, this is what we were going to do. We knew for sure we were going to conduct surveys and town halls to identify some infection prevention knowledge gaps throughout Indiana. Those have been done. And I'll go a bit more in what that looked like. So we've completed those. We are also in the process of creating some really cool infection prevention trainings and modules that are online that are identified by these surveys and town halls as needs. In addition, we are planning to have 9 regional IPC trainings conducted by infection preventionists throughout the state. And we will also present Project Firstline training during during APIC Indiana's fall and spring conferences. We just did the fall one last month and we're very pleased with how that went. Also, we are going to, we're planning a very large, exciting 2-day event in May of 2022 that will be all of Project Firstline's IPC training. So be on the lookout for that. And we also plan to disseminate Project Firstlines to Indiana public schools. And I will go in a bit more in depth with these bullet points so have a better understanding of what we're planning to do. All right, partnership brings greater impact. We could not do any of this without our partners. So I would like to give a great shout out to University of Indianapolis Center for Aging and Community, APIC Indiana, also the IUPUI School of Public Health for their Project Echo platform, and of course CDC. Okay, so we started back in March and April with surveys and town halls. We worked one-on-one with University of Indianapolis Center of Aging and Community to help conduct these. In March, we sent out a great learning needs assessment to all frontline workers, and we found out a bunch of information of kind of where we needed to go to create some of our own online modules. And we piggybacked that with 4 live town halls in April. So we definitely got more of an understanding of what Indiana frontline workers wanted to see and where we needed to go with these modules. So now that we have those informations, we were able to pull a bunch of data from what was needed and what people wanted. And we continue to work with the University of Indianapolis Center for Healthy Aging to create these Indiana specific training modules. These will be online and they're gonna be very cool and very relevant to frontline workers here in Indiana. They will be online and convenient to participate in. We're very excited. They will be released. It takes some time as far as getting different things approved and getting everything finished. So we're in the midst of that and we're pretty excited about it. So stay tuned to see those out and about. And those will also be great for directly with peers and just doing frontline workers and being able to do on their own time. So we just wanted to make sure that these modules are very convenient to take and relevant to everybody. All right, next, APIC Indiana. A big thank you to APIC Indiana for helping us with these upcoming APIC Indiana regional infection preventionists that we're going to help us with Project Firstline trainings. These trainings will be the CDC Project Firstline core trainings, and we hope to have these will be done before the end of May next year. We're looking maybe the beginning of next year to have these started and implemented. And it will be throughout Indiana, depending on what those regions need as far as learning gaps. We will make sure that the trainings are, I guess, picked and fine-tuned for that. So there's a lot of thought going into it. So stay tuned for that. And again, Project Firstline and IPC trainings for APIC Indiana's fall and spring conferences. Like I said, the fall one was a success, and we're excited for the spring conference. And this is an example of the agenda from the fall conference. We had the first 5 trainings from CDC Project Firstline: how respiratory droplets spread COVID-19, how COVID-19 spreads, a review, the concept of infection control, and then we had the other 2 additional ones, review for COVID and also how it spreads from surfaces. So it went with success. We had almost 400 attendees, so it was virtual. We're very happy with how that went. So APIC Indiana is a big partner for us as well. And then I want to touch base again on Project Firstline, the 2-day conference. We're very excited with this. We are working with a third party for help plan it. So it should be very exciting and very relevant to Project Firstline, and we're excited for it to go very smoothly. It will be somewhere in Indianapolis. We encourage everybody to please, if you're interested, let us know. Please send us your contact information so we can make sure that you're on the invite list. This will include all of CDC's Project Firstline's core trainings. We're hoping to have a speaker from CDC come and talk as well, along with infection preventionists. So we're very excited about that. Stay tuned. And then next on our plan for Project Firstline is utilizing ECHO. So we're working directly with IUPUI School of Public Health for the Project ECHO platform. For those of you that don't know, Project ECHO is a telementoring platform where it will be virtual, and there will be specialists and peers are able to consult and talk to each other. And we will go over all of Project Firstline's trainings about infection prevention, and there will be some case studies added at the end. So this is a really great opportunity to work with specialists and I'd like to say the best of the best. So, and also you have access to online ECHO resource libraries. So this will be a continuation. It's not just a one-time attendance. It's going to be approximately 12 weeks and about an hour a week. So we're still trying to figure out, we're kind of locking down the exact schedule and agenda for that. So this will be geared towards local health departments and EMS at this time, and we're hoping for a great success. Oh, and I would like to point out some benefits here. It can increase provider knowledge, skill set, and confidence when you treat patients with complex conditions, improve access to care and patient health, increase job satisfaction and retention. It's a really neat opportunity we're excited about. And this is a kind of a nice visual of what Project ECHO is. It is, like I said earlier, it is telementoring. So it is done from your computer, and you get one-on-one access to information that is relevant to infection prevention. All right, so infection control protects you, your coworkers, your patients, your community. This is another Project Firstline graphic that I really like that I wanted to close this presentation with. It encompasses what Project Firstline is. Any questions?
I'm not seeing any questions in the chat.
I will make sure to put my email down. So if there are any questions in the future that anyone can contact me whenever they want with however I can help. Thank you guys.
Great, thank you. And Tina, if you'd like to introduce Pam.
Yes, hi, thank you. My video keeps going on and off. There we are. Hi, everybody. The second presentation that we have today for the updates from the Indiana Department of Health is COVID-19 updates. And we have Pam Pontones, our Deputy Health Commissioner and State Epidemiologist from the Indiana Department of Health, presenting for us. Pam has served at the IDOH since 1990. She began her career as a microbiologist in the IDOH laboratory and then transitioned into Epidemiology Resource Center in 1990. She served various roles in the infectious disease epidemiology section. Since 2009, Pam has served as state epidemiologist, overseeing many surveillance initiatives, data projects, outbreak responses. In February of 2017, Pam was appointed Deputy State Health Commissioner, assuming oversight for the Epidemiology Resource Center, the Division of HIV, STD, Viral Hepatitis, the Office of Public Health Performance Management, and then the newly created Health Issues and Challenges Division. Pam is the agency spokesperson for the IU Richard M. Fairbanks School of Public Health and is a member of the Delta Omega Honorary Society in Public Health. She's a member of the Association for State and Territorial Health Officials and the Council of State and Territorial Epidemiologists. Pam lives in Indy with her husband and her 2 sons. Go ahead, Pam. Thank you.
Thank you so much, Tina. I really appreciate your kind introduction, and thank you all so very much for having me speak with you today. It's my pleasure to share some information with you on COVID-19, and I really want to thank Danielle for a wonderful presentation on Project Firstline. That was so informative, and I'm really excited to hear about what's happening with that initiative as well. So I'm going to attempt to share my screen. I hope this does it. I'm not sure if this is working.
Pam, if you have your presentation.
Hover your mouse at the bottom of the screen and some options will pop up for you, including a green share screen button. Go ahead and click that, and I suggest you use the desktop option.
Okay, I'm not. Oops. Well, it doesn't look like it's coming up.
We have your screen, yes.
Okay, do you want to go ahead and just advance slides then?
You'll have to do it from your end because you have shared the screen, unfortunately. You should be able to do that with your mouse or your arrow keys.
Okay, so I can go ahead and do that with the mouse, but can go ahead and can everyone see the slides, I guess is what I'm asking?
Yes.
Perfect. Okay, so we'll go ahead and take it from there. All right, so just wanted to share with you, first off, there's a lot happening with the vaccine, COVID-19 boosters and pediatric vaccines. So hot off the presses last week, the FDA, excuse me, Vaccine and Related Biological Products Advisory Committee, or VRBPAC, recommended booster doses for Moderna and Johnson & Johnson COVID-19 vaccines. Moderna booster being recommended for it to be given at least 6 months after the primary series for people ages 65 years and older, and adults who are at high risk of severe COVID-19 or at higher risk due to occupational exposure or congregate living settings. That booster dose is a half dose of what was given during the primary series. There will not be any new formulation or packaging or delineation of this. Rather, it is just simply draw up half of what was given for a primary series, and that is considered a booster dose. So 50 micrograms as opposed to 100 micrograms for Moderna. Johnson & Johnson booster doses have been recommended to be given at least 2 months after the first dose for all individuals 18 and older. Again, no different from the vaccine dose that was given initially. It's just a repeat dose given the same way. So again, these have been recommended for emergency use authorization. That has not yet happened yet. We are awaiting that from FDA and really would expect that today or sometime tonight, early tomorrow, because the CDC Advisory Council on Immunization Practices will be meeting tomorrow and Friday to determine, or tomorrow and Thursday rather, the 20th and 21st, to make recommendations for how and who should receive those booster doses. So we do expect that emergency use authorization at any time. Regarding mixing and matching of primary series and booster doses. So if I got a Moderna primary series, can I get a Pfizer booster? If I got Pfizer, can I get a Moderna booster? All of those different combinations. Looks like at this point, the FDA might be looking to recommend that. We've not heard officially that that is the case. So for now, we're just sticking with everything being consistent, but we are awaiting that recommendation. Regarding the updates to the pediatric vaccine, FDA VRBPAC will be reviewing data on the Pfizer vaccine for kids ages 5 to 11 years on October 26th. So we're looking at next Tuesday. We should be hearing their recommendation for that vaccine. And then CDC's Advisory Committee, again on immunization practices, will be meeting November 2nd through 3rd to issue recommendations for dosage and timing and all of those things associated with that vaccine. So FDA VRBPAC will be meeting on October 26th to issue recommendations for Pfizer to be given to ages 5 to 11. We would expect, if VRBPAC recommends that, for FDA to issue an emergency use authorization sometime between October 26th and November 2nd. So stay tuned for that. FDA did announce on October 15th, last Friday, that they are delaying a decision on authorizing Moderna for ages 12 to 17, excuse me, in order to investigate whether or not the vaccine may have an increased risk of myocarditis. Moderna did submit data on adolescents aged 12 to 17 back in June. Right now, FDA is delaying a decision on VRBPAC's issuing of recommendations until they review that data a little bit further. Also being decided right now, you may have heard of the new antiviral drug called molnupiravir, which is an investigational antiviral drug that is being used and studied to treat COVID-19. So an antiviral medication given after someone becomes sick. FDA Antimicrobial Drugs Advisory Committee, or ANDAC, is meeting on November 30th to discuss the request for emergency use authorization for that antiviral drug, molnupiravir. So lots happening in the space of recommendations and authorizations and more recommendations. Stay tuned, a lot more to come. Wanted to share with you also booster doses being administered in Indiana as of October 14th. Indiana had administered over 210,000 booster doses, which is really those booster doses have made up about half of all doses administered now in the state. You can see the cumulative number in blue going up nice and high. That's what we want to see. pretty consistent in the daily numbers of booster doses given. Boosters by age, if you break that 210,000 number down, who is getting these boosters, we're seeing by far that the older age groups have received the majority of those boosters so far, which is really to be expected because the Pfizer booster has been authorized for all individuals 65 and older, plus individuals 18 and older with underlying medical conditions or who have increased risk due to occupational or living arrangement risk of infection. So 69% of our total boosters have gone to those 65 and older. 87% of total boosters have gone to those ages 50 and older. Again, not surprising given the authorization. Fully vaccinated by age, we did want to share that we are seeing right now in Indiana 56.6% of the population eligible for vaccination, 12 and older, has been fully vaccinated, with 58.7% of the population 18 and older. You can see with the blue bars, our older age groups, certainly we see some higher numbers of vaccination there. Really want to get those numbers increased in the younger age groups, the adolescents ages 12 to 15, 16 to 19, even some of the younger adults really want to get those numbers up, particularly as we head further into the winter and holiday seasons. Also wanted to let you know that a study by the U.S. Department of Health and Human Services estimated that vaccinations have likely prevented around 265,000 infections, 107,000 hospitalizations, and 39,000 deaths of Medicare beneficiaries from COVID-19 just in the first 5 months of this year. So consider Medicare beneficiaries are generally 65 and up. So that age group, just in the first 5 months of this year, huge number of infections, hospitalizations, and deaths being prevented. So really reducing the human toll of illnesses and deaths. Also a huge amount of money saved in healthcare costs. This study used individual claims and county vaccination rates from a sample size of 25.3 million recipients to estimate the impact to the full Medicare population of 62.7 million people. Reductions in deaths were found across all racial and ethnic groups. So really exciting to see the impact of vaccination just in Medicare recipients in the first 5 months of this year. Highly impactful. Moving on from vaccine, CDC has renewed its guidance or refined its guidance on reinfection and actually is recommending to states to consider now reinfections of COVID-19 as new cases. We will be counting those reinfections from September 1st, 2021 and moving forward as separate infections. So we will again be aligning our new reinfections to new and told case counts starting in the next 2 weeks. So just to make you aware of that. But I think what's really important to note is the impact of vaccination on reinfection. Your odds of becoming reinfected if you are vaccinated are 1 in 2,416. The odds of so pretty low. The odds of becoming reinfected if not vaccinated are 1 in 369. So again, vaccines really important to prevent reinfection. So we do see some breakthrough cases, and we'll talk about those, but very rare and really important for everyone to be vaccinated so we can cut down on breakthrough infections that can occur, particularly in individuals who are immunocompromised or who have underlying medical conditions, like we saw so sadly yesterday with General Colin Powell, who passed away due to complications from COVID-19 as a result of multiple myeloma and other health issues that he was facing. Our reinfection rates are increasing, and we do see that our current reinfection rate is 1.2% overall. When calculated in July, our overall reinfection rate was about 0.6%. And we do see with each peak in cases, our reinfection rate increases. So the red line showing where we are today with reinfections, again, looking through this Delta surge that we've had through the late summer and into the fall, as more people become infected, that virus transmits very easily, we may see more reinfections. Very important, yesterday, CDC updated its guidance for individuals who are fully vaccinated. So really wanted to share this with you, and I really appreciate Becky's patience on me getting slides to her last night, because this was some late breaking news we got yesterday afternoon. CDC is now recommending that fully vaccinated people get tested 5 to 7 days after exposure. You may remember that was 3 to 5 days to account for a potential little bit shorter incubation period for Delta virus, which is the very vastly predominant variant we see right now. Further studies have shown that that really doesn't have that much of an effect. So CDC has changed this to be more fully in align with the recommendations for individuals who are not fully vaccinated. So fully vaccinated people do not need to quarantine. It is recommended that they wear masks and they get tested 5 to 7 days after exposure. Negative test result, go about your business, wear your masks until you get that negative test result. They also updated an annex describing the definition of fully vaccinated and vaccination records for people who have been vaccinated outside of the US. And we have gotten several questions from hospitals and healthcare providers. What do we do if someone has been vaccinated in a different country and they come back to the US? Maybe that is someone who has been living overseas and has returned to the US, or someone who has recently emigrated to the US. What do we do? And so CDC now will accept mixed dose COVID-19 vaccines for international travelers. So if they received a dose here, they traveled, they got a dose in a different country, they're now returning, that is acceptable. Visitors who have received any combination of a 2-dose series of an FDA authorized or a WHO emergency use listed COVID-19 2-dose series are considered now fully vaccinated. So if I got 2 doses of AstraZeneca vaccine in England and I'm coming to the US, am I considered fully vaccinated? Yes, yes, you are. That's just an example. If I got a dose of Sinovac vaccine in China and I came to the US, can I get a Pfizer? Yes, you can. So a definition of fully vaccinated to include those other vaccines has now been updated, and these individuals are able to enter the US starting November 8th. And you can check out the links shown on your slide to those CDC websites for much more information. I'd now like to move on to some other updates and data on COVID-19 with you. First of all, the CDC Science update, that recent study that was published, you can see at the link shown on your slide, looking at the excess all-cause deaths that occurred in the United States during March and December, or March through December of 2020. In other words, what was the impact of the COVID-19 pandemic in 2020 on excess deaths? How many more deaths were attributable to COVID-19 than what would normally be expected had the pandemic not occurred? And what was found is that 74%, so over 351,000 excess deaths were attributable to COVID-19, above and beyond the number of deaths we would normally expect in a given year. Those excess deaths were over 2 times higher among Black and African Americans, Hispanic Latinos, and American Indian Alaska Native persons than among white individuals. And you can see that on the slide. So if we look at the proportion of COVID-19 deaths, and this is broken out by males and by females versus non-COVID-19 deaths, we do see quite a bit more excess deaths occurring among the Latino, the Black, and the American Indian, Alaska Native populations. And we've seen time and again where the COVID-19 pandemic has really exacerbated the health disparities that we see in different populations, not just in Indiana, but nationwide. Moving on to our county metrics, you can see our county metrics maps posted every Wednesday on our COVID-19 dashboard, so we will get a refresh tomorrow. We do have some good news this week, and we are seeing our maps improving since about mid-September. Certainly is when I think maybe late September is when we really started to see this turnaround a little bit. We've seen for about the past 4 or 5 weeks that our map continues to improve after the peak of our Delta surge. We now have, compared to last week, this week we have only 4 counties in red. When we look at the 2 metrics of 7-day positivity rate and cases per 100,000, we see far fewer red counties and we see a lot more yellow counties, which is what we really want to see. So our map is improving. We see the same reflection in our cases that continue to drop. We averaged just over 2,000 cases per day this past week, down from almost 5,000 cases at the height of our peak. You can see that we're not seeing too much sawtoothing. This is a consistent downward trend that we're seeing from the peak that we experienced back in late August, early September. So we are definitely headed in the right direction. That is also reflected in our statewide hospital census. This past Thursday, we had 1,634 patients hospitalized with COVID. This is down about 1,000 fewer individuals from our peak again in late August, early September. So a nice downward trend that we are seeing. I touched on breakthrough cases a little bit earlier, defined as infection that occurs in someone who is fully vaccinated. We have been tracking breakthrough cases since January 18th of this year, and breakthrough cases do account for about 1% of all fully vaccinated individuals. So still very, very rare when you look at the total population of people who've been vaccinated. They also account for about 10% of cases since January 18th. And this is all levels of infection. Vast majority of breakthrough cases are mild, which is what you want to see with the vaccine. When we look at the total number of confirmed breakthrough cases as of last week, out of almost 45,000 from last week, we see only 1,568 ED visits, fewer inpatient admissions, far fewer ICU admissions and deaths with breakthrough cases. The vaccine works to prevent severe outcomes such as hospitalization, severe illness, and death. We're seeing a great reduction in those. Is the vaccine perfect? No. And we still do see a very small number of deaths even occurring in individuals who've been fully vaccinated. Generally, they do have underlying conditions that have weakened their immune systems, made it harder to fight infection, which is why it is so important for everyone to get vaccinated so we can cocoon those folks who may not respond as well to vaccine or who are still too young to be vaccinated and prevent them from becoming infected. As we've said several times to different audiences, this fall surge was really driven by 2 things: the Delta variant and individuals who are not yet vaccinated. When we look at hospital admissions, we can absolutely see, and these are hospital admissions over time, where the blue line here represents people who are not vaccinated, the gold line representing individuals who are vaccinated, which is virtually flatline. We did see a little bit of an increase during our peak, again, due to sheer numbers. But when you look at the magnitudes of difference in people who are unvaccinated, this is what really drove that surge. When you look at recent weeks, less than 5% of our hospital admissions occurred in individuals who were vaccinated. So again, the vaccine does work. ICU admissions, you see even more starkly the same pattern. We have also expanded our testing capability across the state. We have partnered with Gravity Diagnostics Laboratory to offer fixed testing locations across the state to make sure that testing access is still readily available as much as possible, in addition to a local health department sites, hospital testing sites, clinic testing sites, and our mobile teams. We wanted to make absolutely sure that we can reach everyone who needs testing. So we currently have 15 counties with active Gravity sites, including 3 that are starting this week in Pulaski, Johnson, and Morgan County. We have added our Gravity test sites to our testing map at our coronavirus dashboard. So testing access, again, still very important to make sure that we are identifying individuals who may be infected, but who maybe have no symptoms or may have very mild illness that we don't want to just assume is an allergy or a cold. When we look at risk, higher risk in individuals with underlying medical conditions, CDC has added quite a bit more information about what those underlying medical conditions are. And sadly, we did see what happened yesterday, or what was in the news about General Colin Powell. Looking at underlying medical conditions, age is still by far the strongest risk factor for severe infection. Individuals 65 and older still account for 80% of the deaths that are reported. But the numbers and types of medical conditions are important to determine if someone is at higher risk for developing severe COVID-19 illness. Some of those conditions occur more frequently than others and can occur among younger populations or skewed more toward certain racial or ethnic populations as well. Risk also depends on how severe that condition is in an individual and how well that condition is controlled. Severe outcomes that we look at when we look at higher risk are defined as hospitalization, ICU admission, need for mechanical ventilation, and death. CDC recently, I think this was last week, added more detail on what defines chronic lung disease, chronic liver disease, what conditions are included in those categories. Also added mental health conditions and autism spectrum disorder to this list as well. No conditions were removed. The list is not exhaustive, and healthcare providers still do have discretion to really determine if someone has a condition that would warrant getting a booster or special precautions to prevent a higher risk of developing severe infection. But this is a pretty comprehensive list that you can see at the link shown on your slide. I looked at this last night. It's very easy to read, pretty inclusive, so would recommend that you bookmark that one. CDC also has issued, as of yesterday, updated guidance for holidays and gatherings. Again, at the links shown on your slide. Absolutely encouraging everyone eligible to be vaccinated to protect those at gatherings who, again, are maybe cannot be vaccinated, such as children, younger children, not yet eligible, or individuals who may still have a higher risk of developing infection. This guidance really reflects the current recommendations on vaccine, masking, social distancing, and outdoor gatherings. Still recommending people who are not fully vaccinated to avoid travel for the holidays, to continue to wear masks in public indoor settings, and still encouraging masking in public indoor settings in communities with substantial or high transmission. And you can again visit the link on your slide. Also, new festival guidance, including small and large gatherings, released yesterday. You can check that out at the link shown on your slide. And with that, I absolutely want to thank you so much for inviting me to share some information on COVID-19 with you today, for having this opportunity to present the latest that we have for all of you. And I'll turn it back over to Becky.
Thank you, Pam. We did